So the gentleman's always been taking very, very large volumes and periods of apnea, but the minute ventilation goes up and down and the blood gases are fine. He has a history of substance abuse. He's on narcotics and stuff like that, so he's kind of doing that narcotic breathing. So he's only on a pressure support of 6. He started with a PEEP of 6, I believe, only. And I might be wrong, 6 or 8. I'll have to go back. But we see here that the distribution of ventilation is quite good, except we have left mid dorsal to dorsal region could be improved. So now I'm at a PEEP of 10. I'm going to do a PEEP right up to 14 in an attempt to recruit this area. We're going to do a PEEP trial, find out the ideal PEEP setting for this gentleman. And if we still can't get this completely opened, I might try a shift of APRB to open up that area. If we can't do it with pressure, then let's use pressure over time. So we'll use like an extended T-high. He's breathing spontaneous. He'll do fine with an extended T-high because he's taking insanely huge volumes with a pressure support of 6. So we'll see what happens. Okay, so let's go up to 14. No real significant changes. A little bit more here. We increased the dorsal distribution by 2%. Okay, yeah, sorry. This was the PEEP of 8, 10, 12, and 14. So we see 8 and 10, there's still some 14, 18% compliance loss, so possible de-recruitment. When we go to 12 and 14, we have good recruitment. We see no white atelectasis, and we see very, very minimal over-distension, or it's in orange, it's indicating with the higher, because as you go to higher PEEPs, you tend to have loss of compliance because of over-distension. Lower PEEPs, you'll have a loss of compliance usually because of atelectasis. So here, with the higher PEEPs, we're seeing that there's a loss of compliance just in this area. The other thing is that if we're trying to open up this area here, you might have to exert some pressure here, and as you're trying to push open that area, you might have orange here until that lung opens. Then that orange will disappear. So it's a question of, are we going to push power into that area to open? We have to know, is this atelectic areas? Is this a consolidated area? It's a consolidated area. Probably not going to want to put too much power there. It's not going to open up. So take into consideration that. Over here we're looking at the yellow for residual volume delay. Anytime you have any yellow within the blue, these are unstable alveoli, cyclical opening and closing. It means residual volume delay. Here we have a compliance win or a compliance loss. So we've won compliance in this region over here, but we're looking to do some good stuff here, and nothing's happening right there yet. And here we have end expiratory lung, so recruitment of FRC slightly here, but we're not getting what we want here so far. We're going to go up to 16, one more, and see if that's a change. And then we'll just do a trial of APRV to see if pressure and time with a higher T-high, exerting a certain pressure but for longer periods of time, will do the trick. Also, since we're concerned literally about the left lower quadrant, we can go to the region of interest and we can put it into quadrants. So now I can concentrate on 4. And ideally, I would like 25% of the volume to be distributed in each quadrant. Right now, we have in area 4, 9%. And this was 9% at a PEEP of 6, and it's 9% at a PEEP of 16. So we're not recruiting but we will set the PEEP where it is still optimal. And okay, so we'll let some time go by, and I'll be back in a few minutes. So over here, this was not connected to the vent, my bad, but we went from 6 to 16, and really we see that the distribution of ventilation kind of increased where the aeration was. We're hardly getting anything in sector 4 with all of this increased PEEP, all right? So this would be considered, you know, in this region, non-recruitable. We can also look to see the regions of interest over here to see if there's any significant increase. Impedance levels are very low, so nothing special happening there either. Now I'm going to start going back down from 16, we went to 14 to 12. So the PEEP study will be done incrementally and decrementally to adjust. If we stay on conventional mode, we'll have the optimal PEEP. Yep, all right. So we're down to PEEP of 10, and I came back because they called me actually, so I was in the middle of doing the PEEP study. I had to go. Upon return with the PEEP of 10, we have a beautiful open lung. There's more distribution on the right side and the ventral. I'm going to do a PEEP study right now again to see if maybe 8 is normal, but either way, we've done some good stuff here. The bottom left that had poor distribution at 9% is now increasing to 13%. So I'm gonna do that on freeze it. See, we're up to 14% now. So I'm gonna wait for the next one, freeze it. Okay, yeah, so 14%. This is great. We've increased to a normal amount with 10. So I'm going to do the PEEP titration. Okay, so I think we've found the Goldilocks PEEP setting. So if we look at the control we had started, unfortunately I wasn't connected to the Drager vent, but then I caught on. But by then we were at a PEEP of 14, okay? Do you remember when I was like, nothing much is happening here, even with the higher PEEP up to 16. So it kind of hovered there, and notice we have a PEEP still at 15. Starting to open up. This was, once in a while you'll see interference. They were touching the patient, but more interference. And then this was they were doing an echo. So anyways, everything, they left the patient, recalibrated, put everything back on. And then after, we're at a PEEP of 10. And the PEEP of 10 is holding the region 4 nicely open. We have 9, we're at 12%. So see, it's nicely opened up. And the color code is saying that compared to here, when you're comparing this to that, you notice there's less white, there's less distribution here because it's been open there, so everything smooths out. So it's saying that air in the reference that was here has been redistributed up here and down here, making a more homogeneous ventilation. Okay. And go back to the main view one last time. And we will put the optimal PEEP for this patient, I believe. At 10 or 12. He's at 12 right now. It's at 10 right now. I would say 10 to 12 is acceptable. All right, and for closing this case, last but not least, final 10, 12, 14 titration, loss of compliance, and the PEEP of 10, perfect pretty much with 12, 14, minimal overdistension. So since I'm seeing white, and he did previously close here, and there's less cyclical opening and closing as well, 22, 14. So optimal PEEP is, in my opinion, we're going to do 12.